so we can move forward. So I'm going to talk a little bit about adolescent weight control, and I'm going to end in talking about parental involvement, but before I get there, I have to build you a little bit of a story. And this not being our typical, my typical audience in terms of weight control, I'm going to give you a little bit of a context, talk to you a little bit about the kinds of work we've been doing and sort of how we evolved into looking at parents more specifically, and then look at the data that we have explicitly looking at parent involvement. Okay, whoops, I already went back. So people know about BMI charts in kids pretty well. So you can't look at an absolute BMI number, you have to look at a percent BMI. And just to show you why that's the case, if you look at what defines the 95th percentile, which is what we use to define obesity in kids. So it's above the 95th percentile for age and sex. Okay? So there's sex specific, this happens to be for boys, there's a comparable one for girls. And if you look at the 95th percentile curve here, you'll see that the absolute BMI numbers are quite different based on the age. So over here, for example, same percentile at 2, that's an absolute BMI of 19, 4, absolute BMI of 17, etc. The later you go into adolescence, the closer those numbers get to what they translate to in adults, so 25 for overweight and 30 for obesity. But that's why we sort of temper everything with a percent overweight or some reference to age and gender. Otherwise, the absolute number makes no sense.
So sorry to stop so early. I always wondered about...
Go for it, Dave.
Do you know when these were norms? Because I always
Yes.
think to myself,
Yes.
it can only be 5%
Right.
obese. If
Right,
it's
right. It doesn't match, and that's true. So these were normed in 2000, and you are absolutely correct that it doesn't work out that 5% of the child population is obese. And there's been some debate about whether norms should be updated. I think it depends on how you look at that. I mean, in the adult literature, the point is not to sort of statistically define based on a number, but more to define where do health comorbidities and risks develop, what are those cut off? And we don't have that as well for kids, but this is the approximation at this point, and so that's the argument for why not change it. Okay. All right, I'm off to a rousing start here. We're gonna get moving right along. So why do we care? So if you just look at this 95th percentile, these are the trends from 1970 to 2009, 2010 here. And if you can start, and these are age groups, so 2 to 5, 6 to 11, 12 to 19, and really very consistently across the age groups, we start at roughly 5% of our population as obese in the 70s, and up to roughly 19% of our school-age kids and adolescents. And that's obesity, so that's above the 95th percentile. If you use the threshold as above the 85th percentile, which is overweight, you're now looking at roughly 1 in 3 kids or teens. So, right, that's why everyone goes a little wild when you start to talk about obesity in kids. Okay. Very quickly, medical risks, there are many. Type 2 diabetes is one of those things that historically was only seen in adults, and we now find that obesity is the leading cause of that in kids. We're seeing it diagnosed quite frequently. And then short of type 2 diabetes, obviously glucose tolerance, insulin resistance, metabolic syndrome, and also associated with pulmonary diseases, obstructive sleep apnea. There's a strong association with asthma as well, at least those things tracking together. I think we're just trying to figure out what those common pathways may be. So increased risk for medical issues. Also increased risk of tracking into adulthood, and the older the kids are, the greater the likelihood. So starting with, if I start with school-age kids, you know, if you're above the 95th percentile and you're 6 to 8, you know, the percent of those kids, 78% of those kids as boys are obese as adults. So that's pretty high already, 6 to 8-year-olds, right? Once you start getting down to 15 to 70-year-olds, 86% for boys, 90% for girls. So some would argue we should just quit right now and all research should be based on prevention. And I think there is a hell of a lot to argue that point. However, we still have a population of overweight, obese kids and teens that we need to attend to. So some of us continue to do that. But whenever I say anything about obesity treatment, I can't say enough about how so much has to be done in prevention. And that's why you see all the policy initiatives. And should we be, I guess the last one didn't make it in New York last minute to, to ban sugar-sweetened beverages of a certain volume and whatnot. But these are all the efforts that are being made, policy level, school level, et cetera, to try to transition this. But then the older you are as a kid, the greater the probability you're going to remain obese into adulthood. Okay, so I probably didn't have to convince you, but now I've convinced you, hopefully. In addition, I'm a psychologist, so I have to say something about psychosocial correlates. Health-related quality of life has been shown across multiple studies that when you look at overweight, obese kids, it's impaired. There was a study done several years ago that got a lot of press where kids were reporting levels of quality of, obese kids were reporting levels of quality of life that were similar to kids being treated for cancer. And so that was fairly controversial when it came out. You can understand why. I actually happened to treat kids with cancer as well. Clinically, and so I was rattled actually myself. But in any case, and the heavier kids are, the lower the level of health-related quality of life they're reporting. So there's a pretty nice linear relationship there. Emotional functioning, there are a lot of data to suggest that self-esteem is decreased, that rates of depression are higher, and then there's a lot of data on weight-based stigmatization. Some really nice papers have come out of Yale. Poole has written some, if you're interested in that topic, some really terrific papers on weight-based stigmatization in kids and sort of the implications of that. Okay, so enough background that we ought to be doing something about this, right? So what have we been doing? I'm going to talk you through just a couple of, and this is obviously a very selected review here because I really want to get to what I've been doing, but just so when I got started with this, it was like, all right, let's develop lifestyle intervention for teens who are struggling with obesity. Very little research done with teens, probably because they are challenging to intervene with, as you all know, or those of you who work with them. And around weight and eating issues, there are some unique challenges. So what we started out doing is, I thought, teens, what do teens care about? They care about other teens. We have kids meeting in groups, but we really don't sort of utilize the group as a therapeutic context so much. So are there ways that we can use the peer setting better to be sort of more of an active treatment component? And so I did a lot of looking around at different models and whatnot. And I landed on sort of a derivative of Outward Bound, if you will. And the reason being, one, it sort of intuitively clicks with teens. There were actually quite a reasonable data, at least in the educational literature, around the use of Outward Bound kinds of models in learning settings and improving learning, et cetera. So we actually did an iteration of that, sort of a scaled back version. We didn't send kids backpacking, on their own in the woods, but we did do things like have them work on activities that were meant to build support amongst the group. I think I took out my pictures, but I'll get to that. And the what I thought is that, if we can get these kids to build more teamwork, we build up their confidence, we build up their social skills, they're going to do better in a weight loss intervention. So what we did, and I'm presenting you this study because this is the sort of background for then looking at family involvement. So we had adolescents and parents participate. I've been doing for a while, depends on who reviews your grant. It's either a very tight methodology or it has no dissemination ability. So, but it's a run-in period where I have people actually keep diet records for a couple of weeks. I don't care how well they do it, but just to give them a sense of, oh, this is a pain. Do I really want to do this? Because if you ask someone, are you interested? How interested are you in losing weight? I get zero variability on anything that would look like a motivational assessment. On the other hand, if you ask someone to do something behaviorally that is what they're going to be asked to do, you get a lot more variability. So we've done these run-in periods where, and they don't have to be perfect, you know, if it was a week, they have to have 5 days that, you know, they did something. And then we randomly assign them to sort of the standard behavioral weight control intervention, and then we either added our peer-enhanced activity based on Outward Bound, or we added a supervised exercise session. So they came and they exercised as a group. I've worked a lot with physical therapy through Hasbro Children's Hospital, so they supervise and coordinate the activity part of things. And then I think I have, quick slide. So we randomized 120 teens, 69% non-Hispanic white. 85% of them completed the intervention, and close to 80% we were able to keep for a 12-month assessment. And then just to show you some data quickly, here are outcomes. These do not differ significantly, but so here is our adventure therapy in yellow at end of treatment, and then a 12-month follow-up, and then the exercise. So they actually look pretty similar. So the good news is everybody did well. The bad news, relatively speaking, is no one did any better. Depends on how you spin it. I'm trying to spin it as we have 2 equally effective interventions. And then actually, I think I have a slide. We also looked at then 24-month. We published this fairly recently and looked at a different metric, which was percent overweight. Again, these don't differ significantly, but what we were able to say is that 24 months after participating in an intervention, roughly they're showing, not so much this group, but this group is showing like a 10% decrease in percent overweight. Does that mean they go from being obese to non-obese? No. But do they lose a significant amount of weight and keep it off? Yes. And so in the adolescent world, this is not bad for a finding. I've never been able to get a study funded where I have a control group that doesn't do anything. So I can't show you that, but I can tell you sort of anecdotally that usually kids would gain weight, or certainly wouldn't be natural. If you look at natural observation studies, they typically would gain weight. Yeah?
So clinically, I know that one of the things you didn't mention was hypertension.
Yeah. Right. Right. Yep. 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 Mm-hmm.
And in adults, when you're decreasing body mass, weight by about 10%,
Right.
you find effects on the blood pressure.
Yeah, unfortunately we didn't measure blood pressure. Other studies have done that and actually have shown decreases in blood pressure, so one would hope. As well as the fact that these kids were at least, certainly we weren't providing them with enough exercise that is what they needed, but they were doing more physical activity, which one would hope could also have an impact there. Yeah?
What sort of exercise were they doing in these groups?
They got to choose. So it was teen-led, which was my mistake, kind of. In the sense of mistake in terms of maybe not seeing a difference. Because I think, so we weren't going to put them all on treadmills or bike, because no one would come back for that. What's interesting about that? So we really sort of rotated it amongst the groups, where each week, either the leader chose, or if a kid had, I just got this DVD, or it's kind of cool, let's do that. Or they would do like shuttle run. The first study I ever ran, we had kids like throwing a football in front of the APC building at Rhode Island Hospital, because it was after hours, there was nobody there. They used to have a grassy area. It was like the coolest, funnest thing. So they got to do whatever they wanted, pretty much, with the idea that if they were there for an hour, at least 40 minutes should be aerobic. So we were targeting that. I took out the slides because I wanted to sort of move through this, but the peer-based stuff, they had to do things. They actually did cliche things like trust falls. We then took them up to a ropes course. Harmony Hill School has a really cool ropes course, and I worked with the person who used to work there and build these ropes courses. So they had to do things like climbing and, belaying each other and all this to sort of and so they really enjoyed it, but it didn't matter. I didn't need to go through that extravagance, as it turns out. to get the same out. There's no outcome I measured. You know, bet improvements in self-concept, decreases in social anxiety, they are across the board the same. So we got no. Okay, so now to sort of get to what we're here for, just to talk a little bit about parent involvement. And I have to start that in weight control interventions with school-age kids, because it is very well documented that parents are a key piece of interventions with school-age kids. So if you look at this, this is dated, but nevertheless, so these are kids who were randomized either, there's a control group here, or they were randomized to focus specifically on the child's weight loss, or both the child and the parent were targeted in weight loss. And you have 5-year outcome data in the green and the 10-year outcome data in the teal, right? So you can see that if you look at the control conditions, they gained weight. The child only were pretty stable. And when you look at the child and parent, it's pretty impressive. These are 15% weight decreases, or decreases in percent overweight maintained at 5 and 10 years. I mean, these are really tightly controlled, they're dated, but nevertheless, compelling data for parent involvement. Since this, we've also had several groups, research groups, working on parent-only interventions. So you bring only the parent, the kid never steps foot, except for assessments, and you're targeting only the parent versus targeting the parent and child. On most of those studies, the parent-only ones do at least as well, if not better. So there's a lot of data to suggest that with school-age kids, so up to roughly 11, you know, probably you can push it with 12, just dealing with a parent is as effective as also bringing a child in. And I talk, you know, when I talk to pediatricians, because they're always asking or frequently asked, like, I don't want to bring this up, I'm afraid about the child, and, you know, what do I do? And I don't have any data for this, but I find myself saying, don't talk to the child, talk to the parent. It's not clear to me that you need to talk to the child based on some of these data. Okay, so well documented in school-age kids. All right, what about parents and adolescents? So what do we know about adolescents? I'm not gonna, you know, I'm gonna present you 1.5 slides on that. That's all you need to know, really. So just to boil it down for sake of sort of space here. There are, Ron Dahl, other people in that group have sort of written about this as, you know, you have sort of this sexual maturation, especially with puberty starting earlier and earlier, but you don't, you know, brain development doesn't come along with that. So you have this sort of out of sync period, if you will, between kids maturing in this you know, pubertal level, physical level, without their brain sort of keeping up with them. And so, you know, what some people have suggested is then that's where you really need parents, because parents sort of can help with the brain power, if you will, the ego control, however you want to call that, in these kids who, while they're developing and have impulses and all of this, may not be able to regulate so well. So in weight control specifically, there were 2 studies done quite early suggesting exactly the opposite of each other in terms of parent involvement. One showed that kids did better, parents and teens in separate groups, getting the same content, that was superior. Another one, I wouldn't say exactly the opposite, but another one showed that it didn't matter what you did. You could talk to only the teen, you could talk to, they didn't have a parent only, you could talk to the parents and teens together, it didn't matter. They did roughly the same. So what we did sort of is do a secondary data, where I started with this, is to do a secondary data analysis from, based on the research I just showed you. We had parents coming every week, and they were recruited to support their teens. So meaning they had to come to groups every week. We always asked them to modify the food environment at home, modify the physical activity environment at home. I also started asking parents to keep food records for the first 4 weeks, and this was my clinical hat, because parents could be, I noticed, extremely critical of their kids, like, oh, so-and-so didn't do this, they didn't fill it out right. So, you know, it just bugged me. And so I decided to ask them to do the same thing. And they were a little bit humbled in that context. It doesn't matter. Like, you can do paper journals. You can have them do it on, there's so many apps now to do this. It doesn't really matter. It's just the process of recording what you're eating and what activity you're doing. But anyhow, and our parents weren't selected on weight status. And then we just looked at sort of what were their relationships. So pretty strong, significant relationship between, we didn't ask parents to change their weight, right? But when you looked at parent change and teen change, pretty highly correlated. The other thing is that if the parents did the diet records, the teens tended to do the diet records. So yeah, a little more interested in this. And then we sort of did this very crude but chi-square kind of thing where we looked at, sort of defined successful, not successful. You could argue with what our definitions were, but for teen weight loss. So we said, 16 weeks, if they lose a half a pound a week, I'm going to call them successful, relatively speaking. So these are our kids who lost 8 pounds. And then we just divided by parents who basically maintained or gained versus lost any amount of weight. And when you look over here, you'll see that if the parents lost weight, right, the odds ratio, you have more than twice as many teens losing a significant amount of weight if their parents also lost weight. So then I thought, okay, great. We ought to be looking at this more directly. Why don't we specifically get parents involved and target them? And there were lots of reasons for doing that, for thinking that if we could get parents to both model healthy behaviors and get them to be more accepting of their teens. There's a lot of data that I can't get into about kids around weight issues get teased a lot. Well, they don't just get teased by peers, they get teased by family members, and they get teased by parents as well as siblings, which is sad, but the reality. So we thought, well, maybe we can do something where we actually train these parents to be, look, even when we're not trying to train them, they're having an impact. And so I naively thought, oh, if we really sort of target that, we could get them to have even more of an impact. So we got funding to do a small grant. So this was 49 adolescent parent dyads. And this was short term, so if you know the budget of an R03, you really can't do a lot. But it was a 16-week intervention. We did assessed BMI, parenting domains, who took responsibility for different weight-related tasks. Yeah.
How old were the adolescents?
13 to 17.
Okay.
I'll show you in a second. Yeah. And then we looked at their communication. So this was the intervention, 16 weekly groups. Same thing we've done before in terms of the weight control components. So that's this. And then what was different is for the kids where we randomized either enhanced parent or minimal parent. Enhanced parent, parents had to come each week. We had parents target either weight maintenance or weight loss, which meant they got weighed every week as well. So that added an interesting dynamic. And then we also targeted improved communication. So I work in a place where people work in all different health-related behaviors, and one of the groups, Larry Brown and his colleagues work on, reducing sexual risk behaviors, and they have a terrific intervention on improving communication with parents and teens. So Wendy Hadley and I took that intervention and adapted it around weight-related behaviors. So I thought it was a decent intervention. So for that part of things, parents and teens did role plays. We mixed them up. So we did different dyads, role playing with each other. So your parent would, talk to somebody else's teen, so to deflect all of that high tension and whatnot about that. And then they actually got up in front of the group and did a role play in front of the group, or did a interaction task in front of the group. So that was, I guess we like building to crescendos in our interventions. But in any case, in contrast, if you were minimal parent, the message was, all right, parent, you stay out of the way here. Your job is to have healthy foods available at home. We're going to work with your teen on this, and really, let them be. You can call us if you need to talk to us, and I met with the parents at the beginning, the middle, and the end, without giving them a whole lot of guidance around anything other than the nutrition side of this. 13 to 16, 95th percentile BMI or heavier, and absolute BMI less than 40, and that's just because there's not a lot of evidence that lifestyle interventions of this intensity are going to be effective with kids with BMIs greater than 40. We do groups, so we've limited to English speaking, at least at this point. Then here are our baseline characteristics by group. So as fate would have it, in small samples, randomization doesn't work so well. You all know that, and I can show you that here. Based on, we had a significant difference actually in BMIs from the beginning. So our enhanced kids were slightly heavier with BMI. So what did we find? So both groups of teens lost weight or significantly decreased their BMI. There's a trend for an interaction, exactly in the opposite direction. So in our speak, we have a decrease of 1 BMI unit. That's for the minimal parent condition, and half of that for our enhanced condition. And then to make it even more complicated, we have a trend for a time by condition interaction in parent BMI change. So, and this is the only study I've ever done where parent and teen BMI change were unrelated, completely unrelated. So, and then just secondary outcomes. So we also looked at, because we were looking at modeling, and we don't have enough of a sample size to run any complex models, but just looking at what were we looking at as the mediators of this relationship, or the mechanisms. So we looked at healthy eating behavior in the parent. So this actually is a significant effect for time. So both groups of parents at least reported that they started doing healthier eating things. It's like portion control, eating more deliberately, paying attention to what you're eating, more fruits and vegetables, et cetera. And then this is the great one. So this is an interaction. This is negative maternal commentary, okay, about weight in particular, okay? So this is an interaction, and guess who's decreasing more? I mean, these are not huge. You have to keep track of the scale, but nevertheless, so it's our minimal group that's decreasing. Our enhanced group is staying exactly the same. So I'm happy to have you all, because I'm trying to figure out what my next steps are from this fascinating data. And then just to show you, because one of the other things we looked at was responsibility for weight-related behaviors. So for example, who keeps track of what the teen is eating? Who does the food shopping? There's a well-established measure in the area of diabetes, actually type 1 diabetes. And so we took that and modified, and it actually held up pretty well in the study in terms of reliability anyhow. So this is not significant, but just it's in the direction you would expect, which is that, our enhanced group, this is teen responsibility. So they increased their responsibility by about 2%. In our minimal group, the teens increased their responsibility for weight-related behaviors about 10%. So not significant statistically, but interesting. The other thing I don't have on here is that more increased responsibility on the part of the teen for weight-related behaviors tends to be related to better BMI decrease. Okay, so I invite your comments. I'll tell you what my comments are. But so contrary, and I've actually have this 90% written up, so this is very timely. When we explicitly focused on these behaviors, tried to have parents be strong role models and really looked at, how do you talk to your kid about weight, not to be teasing, not to be negative, all of that, it didn't work. And in fact, there's some indication that if we give more responsibility to the teen, we may be doing better. Now, anecdotally, and I have no data, I'll tell you, I heard a lot of kids say, why should I do it? She didn't eat that way this week. She didn't eat healthy. She didn't write down what she was eating. So if you're going to have a role model, you better have a good role model. Otherwise, you've completely sabotaged yourself, right, by what you're, so yeah.
And is it possible that some of the negative commentary from the mom might be sort of defensive commentary?
Sure.
Because
sure.
the
Sure.
child
Sure.
is saying to
Yeah.
the mother,
Yeah.
well, you didn't do it, and then
Right.
the mother is sort of,
Right.
putting it back at them as well. So.
Absolutely possible.
Yeah.
So I think we created sort of this hotbed of, even though we were working pretty hard to, and it's not like these people were incredibly critical of each other to start with or anything. These aren't people who are calling each other names, but I think it's very easy in the context. People get very agitated and affectively laden when you start to mess with comments about weight, comments about what they're eating or what they ought to be eating, highly sensitive stuff. And so I think it's interesting. So it sort of had the reverse thing, but this is my best guess about. Anyhow, so lots of limitations, certainly. We had a small sample size. We also didn't restrict to obese parents, which, we certainly could have done, but for reasons of just wanting to get in. We also didn't restrict to, for example, mother-daughter, father-son, because these relationships look quite different, obviously in general, if you look at the adolescent literature, but then specifically around weight and eating as well. There are lots of ways that plays out differently. And mothers and daughters, this is a particularly loaded area. So where am I going? I don't know exactly. Based on, I have other directions that I'm going, but we do have videotaped interactions. So we did that at the beginning and the end, and those are very close to being coded. So we'll have some more, relatively speaking, objective data around how are they actually talking to each other, and does that change over time, and what did our communication intervention actually do or not do. But I just wonder about, and at this point, I don't think we're asking questions about should parents be involved. I think that's a very simple question. It's more about how. And is it better do you actually in some way get in the way of sort of a natural autonomy, I'm going to take responsibility for this. We're not talking about risk behavior here. We're talking about where, when I talk to other colleagues, it's like, well, they need to be monitoring. They can't have their kid out. It's not clear to me that monitoring in the area of weight control is a positive thing in teens. In fact, you might argue the opposite potentially. So that's where I'm at. If anything, I'm leaning toward we want parents to be involved. They need to detoxify their homes, if you will, and they need to make it easy for their kids to eat healthy. But I think we probably need to be encouraging a lot more autonomy in these kids so that they internalize some of this as well. But okay, sorry, that's it for me. Yeah, go jump. That's cool.
That's really good. I'm wondering if you collected data on sort of potential determinants of obesity among the children to begin with, so maybe, and also the determinants of the maintenance of obesity. So, for example, are the kids who have is it related to parental obesity, or is it related to mental health related stuff? And because I wonder.
In this sample, no, but in general, there's a decent relationship between depression and obesity. It holds up better longitudinally than cross-sectionally, where depression predicts obesity. So adolescent depression predicts later obesity. In terms of the predictors, no. The genetics is the biggest, even though we can't really identify what part of that, but the heritability estimates in obesity are like 80%. That's high. They range, but that's the high, but if you look at a genetic study, we account for about 4% of the variance, so I don't know where the rest of that's at. But in terms of those other kinds of things, it's environmental. Like, what I didn't show you is if you look at sort of in general, what do people think accounts for obesity, you really need to look at multi-layered, sort of a socio-ecological model where you have certainly the kid's biology, the immediate family in terms of genetics, but also what kinds of interactions. But then you have huge environmental contributors to obesity as well. I'm not sure if what were you thinking?
Well, no, that kind of answers my thought process, but I was thinking about, needing to maybe address some of the other, it is ultimately about the food, right? It's sort of like the input.
It's energy in, energy out.
Right.
Yeah.
So, but it's, depression is
Right.
increasingly like
sort of reasonable data on doing just that and getting that. So my question is, why don't these, and these kids were not depressed, so they weren't clinically depressed. So the question is, why would they do worse with more parental involvement? You know, they did okay without the parents, actually, and it's more cost effective, I would argue. But we have a study that's wrapped up. You have to go do your time. But we have a study that's wrapped up right now where we're looking. We actually did depressed obese kids and gave them depression treatment alone versus this integrated treatment that included the obesity stuff. We didn't move obesity very much, but all the kids did better with depression. So anyway. Thank you.
It's interesting that you mentioned humbling at one point in the talk, because I feel like these pilot studies and these attempts to address multiple risk factors or take multiple approaches often are very humbling, because I think we don't necessarily know. It seems like it should line up theoretically, but it doesn't always do so. So really fascinating. Thank you. So our next speaker is Margie Skeer, who's an assistant professor at the Tufts University School of Medicine in the Department of Public Health and Community Medicine. She's also an adjunct assistant professor of behavioral and social science with the Center for Alcohol Addiction Studies, and was a postdoctoral fellow here. And so we're delighted to have her back to talk about some of her current research interests, focusing on substance misuse and sexual risk prevention, both from an epidemiologic and intervention development perspective. And she'll be focusing particularly on substance use today. So welcome, Margie.
Thank you, Chris. And so I'm going to be talking about the role of families also, and I think this was a really nice pairing of Elissa and myself in terms of our work and thinking about parents and the roles that parents play in adolescent risk behaviors and other outcomes. And I actually have a different spin, because I'm just gearing up to literally start recruiting for a study like tomorrow, once the IRB approves the recruitment material. So I'm going to talk a little bit about sort of my thought process around prevention and whatnot for the study that I'm currently conducting. This crowd over here, I think, mostly knows that substance use among adolescents is bad. Right? I don't know. Does everyone here know that? Do I need to make an argument? So I don't actually have much. I don't have epidemiologic data, but if you don't know that, trust me, it's not good. So the work that I do, a lot of people in the Center for Alcohol and Addiction Studies here at Brown focus on treatment, and I was kind of the person who came in and said, prevention. So as you were saying. A lot of people will now focus on the prevention side, and yet treatment's still important. I'm coming sort of from the opposite. So, is this okay? So we have the Institute of Medicine's continuum of care, where we have prevention through treatment and then maintenance in terms of substance use. And my focus is on prevention. And so we have our universal, selective, and indicated, where we're looking at groups of people in universal that don't have, everybody is sort of lumped in together when nobody is necessarily at higher risk or lower risk. They're just all lumped together, and you kind of focus the interventions to everybody. Selective is when there are some risk factors, and indicated is when people have already started dabbling in substance use, and so the risk factors are even higher. And so I'm focusing on universal prevention for the current study that I'm going to be talking about, which is, let's see if we can push the population distribution slightly, in which case we still get a large public health effect of trying to reduce substance use among adolescents. And the Center for Substance Abuse Prevention, CSAP, through SAMHSA, has this really excellent definition of prevention. And the things that I love about this definition are that they talk about it as it is a proactive process. Right? That's great, right? It's really something we need to be actively involved in. And so it's this proactive process that empowers both individuals and systems to meet the challenges of life events, and not only life events, but also transitions, which is really important among adolescents, from going from, you know, early age, younger adolescent, you know, preteen, tween area, then getting into teenage years, and sort of beyond. And that's a time that we really need to focus on prevention efforts. So we're meeting the challenges of life events and transitions by creating and reinforcing conditions that promote and healthy behaviors and lifestyles. So we're really promoting these behaviors, these lifestyles, and trying to do it from a systems perspective, and we're doing it proactively. So I love this definition, and that's kind of where my work has been targeted. And so I think about prevention, and a lot what Elissa was talking about in terms of, you know, thinking about children within the context of their larger system. And so you have I have a thing here, I don't need to stand in front, sorry. We have the individual, and with me, I think a lot about family, because we know how important family and parents are in the context of young adolescents and preteens. So the family environment, we know that the family environment is very, very important to adolescents. And the pieces that, especially around substance use, that we have, that have shown to be effective, and this is exactly what Elissa was just talking about, that was hypothesized in her study, is open communication, monitoring, and family cohesion. And so when you take these pieces, we know that is effective at reducing the risk of substance use and sort of a whole host of other risk behaviors, maybe not obesity, but other risk-related behaviors among youth. And family-based interventions for adolescents around substance use have been shown to be effective. And so family meals. I think some of you have heard me talk about this before, but years ago, probably 10 years ago at this point, I was at home watching television and I saw a public service announcement that there was a coach, and he said something like, you know what the #1 way that you can help prevent your kids from using drugs and alcohol? And he opens the oven and says, eat dinner with them every night. And I thought, wow, could it be that simple? You know, could it actually work? And what is that? And so then when I came to Brown, I started looking at this more, because that always sort of stuck in the back of my head, like, this is so fascinating. Could that really be an intervention? And so I started looking into the literature, and it's true that there's been a lot of research done showing that eating meals as a family reduces the risks of smoking, drinking, and using other drugs among youth. And this has been shown both cross-sectionally and longitudinally. And we know that the rates of people eating meals together as a family has gone down drastically in the last several decades. Huge, huge reductions. When I was looking at the literature, I noticed that all of these studies that have looked at the relationship between family meals and substance use have all been observational. There had not been any studies that had actually tried to manipulate, either increasing meals or promoting meals as an intervention strategy. And I thought, well, here's my opportunity to be innovative. And so then, you look at these studies and say, okay, the evidence, at least observationally, is there. Why are family meals important? And I started thinking about this a lot, and I started looking into this, and I realized that there's really a lot going on. One, this is a time where children can be with their families it could be every night or whenever people decide to do it, but it's a time that is consistent. And the consistency is really important for youth. Knowing that their parents are there, that they're there during a certain amount of time, and that they're going to ask them questions and listen to them is really important for providing that foundation for open communication, for trust, and for knowing that your family is there for you. Also, when you don't have a baseline level of communication with a parent-child relationship, you can't start talking about really hard things to talk about, like drugs, alcohol, sex, even weight. These are very sensitive topics. So if you can't ask your child about their day and you really don't have a good relationship or you don't have any kind of communication, how do you start talking to them about sex and drugs and these other really challenging behaviors? And then another thing is that meals, again, it's the time. So meals provide this time together that parents can sort of establish and understand patterns with their child. So if all of a sudden their kid starts talking about different friends, they start wearing different clothing, they start talking about their grades, or things start changing, that can be an evidence that's a risk factor for, or that it's a sort of symptom of substance use or other things that are going on in their lives. So all of this stuff is happening at the family meal. Do you have a question?
Yeah, it's a stupid question maybe, and maybe it's just indicative of my family, but this presumes there is some amount of communication going on in the meals. You're not just staring at each other with this frustrating noise.
Indeed. And there is a decent amount of evidence that if other things are going on at the meals, like watching television, that sort of negates the positive effect. And this also assumes that there's not like a very contentious relationship going on, right? So if you are sitting there because you're required to, but you hate your parent and you are looking at each other with contempt, that of course changes it. Because it's not the meal, right? It's not actually the meal where you're eating. And you can correct me if I'm wrong, but the literature around the positive effects of family meals on adolescent risk behaviors is different than that of the effects of family meals on obesity, because there's a large literature around family meals and obesity, right? But the mechanism is different, because the mechanism, like we said before, for obesity is the food that's going in your mouth. And that could be around like support and communication also, but that's sort of that mediator is the food. Whereas for risk behaviors, I would argue it doesn't matter what you eat at meals. It doesn't matter if you're eating fried chicken every night, but that you're doing it together, because that's what's actually creating the environment of communication and trust and all that other stuff that's going on. Am I wrong? Is that? No. Okay. Oh, okay, yeah. Right. So that's where I am with meals. I think about this a lot. So, and then, in the substance use literature, there are these model programs, these programs that have been shown to be really efficacious, but I find them challenging in some ways because they're these the prevention programs that are very labor-intensive, resource-intensive, and they're really effective, but in the real world, I don't think that they would necessarily bridge this gap. And we need, as researchers, we need to think about translation and dissemination of research. And so if you have a program that's 2 hours a week for 14 weeks, where you have to have parents and children, and you're not paying them to come, and who has time, how are you going to bridge this gap? And I think of brief interventions, and coming as a CAS fellow, that's something that we do here in the treatment realm. And so, I brought that to the prevention realm. So this is all to say that I developed an intervention. It's called the Supper Project. I worked long and hard on coming up with this name. So substance use prevention promoted by eating small family meals regularly. So this doesn't make it in, but I was proud of it, and I wasn't gonna move away from it. So this is the Supper Project, and the focus of this is really promoting family meals as a communication strategy and trying to increase communication, increase monitoring, and then increase communication specifically about substance use among parents and pre-adolescents. And hopefully this is not the picture at the end of the study, but we think of parent-child communication, and this is what we think a lot. So my hope is that that actually is not the case. So this is a sample of parents or guardians from one K through 8 elementary school in Boston. It's a Tobin school. This is a picture of it. And it's a largely Latino and Spanish-speaking population. The study design, it's funded by NIDA. It's an R34, so it's a 3-year pilot study. We're doing an uncontrolled pilot of 20 people. And this is going to be my really excited sample who are so jazzed to join my study. That's not them, but it's going to be. And we're collecting data at baseline in 3 months. We're using computer-assisted survey instrument or self-interview, to collect the data. And we're taking this uncontrolled pilot, doing exit interviews with everybody, and then refining the intervention accordingly. And then we'll do a pilot randomized control trial to see if the intervention works. And the components of the intervention are a handbook. So this is, these are the covers of the handbook. We work with a graphic artist to develop these really beautiful handbooks. They're 8.5 by 5.5. They're about 20 pages or so, take about 20 minutes to read because we've done pilot testing on them. I wanted to take a lot of the information, boil it down into something that is actually tangible. Parents can hold it, they can open it, they can read it, put it in a bag. And so because it's a largely Spanish-speaking population, we have in English and we have in Spanish. It's gender specific, so parents of daughters get a different handbook than parents of sons, because we know that the reasons that boys and girls use substances are different, and there are different statistics around their rates of substance use. So my thought was we should make this a gender specific intervention, because a lot of the longitudinal evidence showed that this was maybe effective for girls and not for boys, and so I thought let's try to break this down. So they get a handbook. They meet for one time for about an hour with an interventionist, and we hired interventionists. We have a native Spanish-speaking interventionist, and then we have 2 English-speaking and native English-speaking interventionists. I'm one of them as a backup, and the second is also fluent in Spanish. So we're hoping that that'll be able to bridge with the community. And so the meeting with the interventionists will basically be going over any questions that the parents or guardians have about what's in the handbook, or then anything specifically that they want to talk about more related to their family situation. And we have a list of referrals and resources. And then after that meeting with the interventionist, we'll start getting 2 text messages, one text message twice a week for 13 weeks with information from the handbook. And then the text messages have page numbers associated with the handbook. So that these are our little like boosters, these kind of cognitive cues. And we've created a magnet that they can put on the refrigerator that has a lot of the information. So stuff like try to eat meals with your child, talk to your child, communicate, know where they are when they're not at home. The little, sort of the major bullets of the handbook are going to be on this magnet. And so our outcomes, primary outcomes, so this is the RCT is a 6-month follow-up, and we're working with 9 through 12-year-olds. So this is not really enough. This isn't enough time to see if 12-year-olds are going to be initiating substances, because they're really not at that point. Some, but some do. But the prevalence of substance use among even 12-year-olds is very low. So we really are focusing on the sort of the intermediate outcomes, which are parent outcomes. So we're looking at, do they increase family meals? Are they increasing their conversations about substance use? And then what's their parent-child communication, and then the monitoring. This is sort of less so because, again, kids are still younger, but these are things that we're thinking about. And then we do have child outcomes of intentions to use substances, and then their expectations and attitudes around substances. And then as a secondary outcome, we will look at initiation of alcohol, tobacco, and other drugs, although I don't expect that we'll see much. I don't know. So in the interest of time, I'm not going to really talk much more, but we've had some stumbling blocks, and our next steps are to start recruiting this week, test out our CASI to see the uncontrolled pilot is really only with the parents. We're only going to include about 5 children in that component just to see how the CASI is, if it's too long, if we need to refine it. And then for the randomized control trial, we'll include parent-child dyads. And then we'll refine the intervention and conduct the randomized control trial. That's it. Any questions? Yeah.
So, how much do you expect that the conversations around substance use will happen at a dinner table as opposed to elsewhere? And does the manual and the final version sort of give guidance about when that should happen? I mean, I imagine that people often have other kids at the table and so on. So, how do you help parents deal with that?
Yeah, well, we say that that doesn't need to actually happen at the dinner table, but it needs to happen. And we also say it's something that can't happen just once. So the handbook does talk about, this is something that should come up, can come up at the dinner table. It doesn't necessarily happen, or whatever table, breakfast, lunch, whatever parents are doing. And that it just needs to happen. And it needs to happen sort of, not necessarily frequently, but more than once. And this is these are ongoing conversations. And we give recommendations about ways that they can bring it up. Like, for example, if a celebrity is arrested for drugs, this is a perfect opportunity to start a conversation. If somebody in the news, something else in the news or something in the neighborhood happens, or somebody gets, your child starts talking to you about their friend who X, Y, and Z, or an older sibling, these are the opportunities. You need to sort of take these opportunities when they come up, because it's awkward to just be like, so let's talk about drugs today, So we give some kind of guidance. And the other thing that I didn't mention is the other thing that we give guidance on is that, like I said, meals are important because they provide this space and time, but not everybody can eat meals together. So we do say in the book, if you can't eat meals with your child, find a time, about half an hour, at least 5 days a week, that you can spend with your child specifically talking with them, period. Not just about drugs, but talking with them. So if that's you're taking a walk together, if you're eating a snack together, if it's you're going to school, it takes a half an hour and that's the only time that you have, but you're talking to each other, you're not singing on the radio, you're just spending that time concentrated, being together. So you have that time that your child can consistently count on you. And we can't provide everything. It's a short handbook, and that was by design so that parents would read it. But that's why we have the interventionist meeting too, so that they can have that one-on-one time and ask, and those points can be sort of hammered in by the interventionist. So yeah.
Yeah, so I had 2 questions that have to do with methods, and one has to do with prevention, but the other one has to do with adolescence in general that I think relates to both talks. So in terms of prevention, so I went to, like a few years back, NIDA was getting into this idea about exercise as a potential prevention for substance abuse. And one of the issues, so I was at this NIDA meeting where they were developing like the PA or the RFA or whatever, and one of the issues that came up, that was a tough one, is when you're dealing with prevention and the base rates are so small to begin with, and you want to show evidence that something like exercise or eating family meals actually has an effect, to design an RCT that has enough power to detect those differences and to measure it so many years out is nearly prohibitive.
Yes. Agreed.
So I just want to see if you what your plans are sort of going forward, and whether you think NIDA, it looks like we'll look at the meals themselves as the outcome, or where you need to go with that. And then the other question has to do with comparison conditions. So I know Elissa, you mentioned that it's tough to get with adolescents. I'm guessing because of ethical issues, a comparison condition that involves no treatment. So this also kind of plays out in how do you sort of show evidence that a certain kind of intervention works to help adolescents lose weight, or in your case, that what kind of comparison condition would you use so that you could test this idea that and would it be ethically appropriate? So sort of issues, I think, especially for adolescents.
Yeah. So to address your first question on method, on sort of on RCT for prevention, it's totally prohibitive. It's something that I lose sleep over at night over, because you know, just measuring prevention in and of itself is so challenging. You know, NIDA funded this, so. Yeah, I mean, one of the reviewers' comments was, you know, this might not work, but it might, you know, and right, exactly, exactly, and it is really hard because, especially because my age range too, right? So even at the 12, like if you did a 3-year follow-up, we're still looking at lower rates of initiation. So it might be that I need to change my age, or still kind of look at these more intermediate outcomes. Or, you know, look at that. I don't know. I'm just trying to start my pilot.
As you think about your pilot, does it seem like this is, as you develop this a little bit far, is it feasible to do it in, you know, 5 schools versus another 5 schools? I mean, is this?
You mean for an RCT?
Yeah. I mean, is it, because I know you have the interventionist. That's the one piece that's sort of maybe harder to scale up for the school model.
Right, and that would, yeah, that would be the limitation on sort of wide-scale disseminability. But that's what I would want to do because of the contamination issue. I would want to do it by school, and you know, it's really a minimal intervention. And so I think schools wouldn't be that, you know, scared of because we don't ask the school to do anything except let us recruit. We'll see how that pans out. But I do, you know, it is certainly challenging.
Yeah, but that's a good point. I think Chris is making too, is that to think about the R01 as you're doing this, you know, the R34. So it's like, what kind of information would you need to satisfy reviewers for the R01?
Right.
Is it worth it even to go in and do a survey with principals or administration in 6 other schools to say something like, oh yeah, we would be agreeable to that sort of thing too, even if you don't have the data.
Yeah, that's a really good point. And I was actually just speaking with Tony Spirito, who's a co-investigator on this, and thinking about, you know, if we get all, you know, if all 20 parents in the uncontrolled pilot are motivated parents and they're all eating meals together, you know, then we're not going to show an effect necessarily. And so, but that's great that we have the uncontrolled pilot, and you know, then we need to sort of assess. And I think it's wonderful that we have that first phase, because that will allow us to sort of understand what the pilot RCT will look like, and that will give us information about applying for the larger R01. Oh yeah, we didn't talk about your other, sorry.
Well, I guess I feel like you know that people would do worse with nothing, but just the idea of who's going to sign up for a research study are probably people who are motivated to begin with.
Right.
And then the fact that they're getting some attention and they're getting assessment. Similar things happen with physical activity, right? So it's like people in our physical activity trials, if they weren't enrolled in our study, they continue to do nothing. But the motivated people sign up, and even just with assessment, if we do nothing else, we see those comparison conditions going up. And of course, there's not as much of an ethics issue with physical activity as it is with teen obesity, you know, or substance use. So we do use the control conditions, and we still see them going up. You know?
And this type of work is a little bit different than trying to treat obesity or even treat substance use, because a control, a no treatment control, actually is not unethical necessarily, because it's.
And there are no data. So
right, right. On top of it, right, there are no data, but. Right, right. So it could be that everybody in the sample actually isn't at risk for substance use, and you know, so this is, I don't think not having a comparison condition as opposed to a control condition is unethical at this point. Although we could, you know, down the road we could maybe try to do like a 3-armed type where we have maybe like a nutrition intervention as opposed to, you know, the family meals to substance use intervention, to see if there are differences in like meal patterns and communication around substance use. Yeah.
What is the rationale for your age group? And then do you have a sense of
answer to your second question is no. I did pilot the handbook with a sort of a convenient sample of 15 parents, and it was sort of mixed. Some were having a lot, and some were having none. One woman I met with was actually scared to death of having a meal with her child. She was a single mom, had an 11-year-old, had never had a meal with him, or so she said. But she was so scared of him using drugs too, because they lived in a neighborhood where there was sort of drug use even on the corner. And so it was sort of variable among these 15, but we'll see what happens. Right, exactly. But if there's also an increase in communication and communication around substance use, then that would be an effect of the study. And your first question was, the sample size, the sample age, right? So from a prevention standpoint, my ideal study would be getting mothers who are pregnant, doing this work with them, and then following them up for 20 years. That would be my ideal, because the truth is, these are parenting skills. This isn't rocket science. This is just like parenting. So, but from trying to measure stuff, this is really right at or before the age of initiation, because 11, 12-year-olds do start a little bit, but it's not really until kind of 14, 15, and even older that the initiation around substances starts, at least on a national level. And so we needed it sort of long. We needed them to be old enough that these kind of interventions, we'd be able to look at monitoring a little bit, and also communication, because you can't really. It's hard to have communication around substance use with a 4-year-old. So they're sort of old enough that they can understand the concepts, and they probably already started hearing about it at school or friends, or on the listening to music or watching TV, but not so old where they're already sort of entrenched in potential initiation rates. So that's where the rationale came from. Don, did you have a question? Another question?
Well, despite what I said earlier, I do think the family meal approach is a potentially very elegant kind of platform for intervention.
I'm worried about it.
Right, I know, right? So don't recommend it if it's an obesity.
I think that's where my memories lie.
Yeah.
So I'm thinking about it for your sake, because what you said about it provides a space for the messaging that you're trying to coach the parents on. And maybe for your study, did the parents have a context within which to talk to their kids about? Did they know about there are some times where it's more
Absolutely.
effective?
I didn't go through all the details of the intervention, but we did the whole thing about the timing of conversations, body language, verbal, nonverbal cues, and so I think we did a very big so we took the HIV prevention space, we modeled it based on, they had a day-long intervention that they studied in a private style with Rins as well. And we took that and sort of broke it down, so instead of doing a day-long, we broke it down so it could advance it things. And obviously didn't really talk about putting condoms on penis models, but maybe we should have. That would have been very innovative. Talking not about weight.
But it's interesting because you may be throwing them into the mix when a lot of the communication problems and disturbances and some of the adolescents are already sort of actively going. So it is really
Right.
interesting to think about the staging and some of these things are easier or harder.
Right. Because that stuff's so loaded. It's so sensitive already. Yeah. As a heavy adolescent, I remember my grandmother taking a knife and hitting me in my hand when I went for an extra helping of something, and it's that stuff has clearly stuck with me,
No, it really is. Because we started this with saying, if we can get parents to talk about, this sensitive topic, and, Wendy would say, no, this is hard. Because there's a personal state, people are very, there's a very personal thing with one's baby.
Yeah, and it's hard too. Because parents, they know probably how bad it is for their child to be overweight, and they hear. I think as a culture, we're sort of saturated with that. And yeah. And then there's judgment among everybody if there's, an obese adolescent. And like,
That's the other thing. I say to people, my colleagues do not know if I was depressed or if I was a chain smoker, if I did it well enough, but boy, they're going to know if I'm obese.
it's true. That's true.
That's the first thing when people
Right. They see. Right. You can't hide it. Did you have a quick question? Because I know we need to end.
I see that you're looking at family, and I'm just concerned about some of the other methodological, upstream issues that might be impacting in your intervention. I'm not sure the demographic split that you're looking at, sort of if it's, what income level or educational level, and what impact that might have, what substance use the family might already have, and so, how those might interact and actually set the intervention if the intervention might be failing because they're not being thought about. So it's just really looking at that. Perceptions related to what people are doing, where they're walking.
Yep.
If there is boredom that what's driving kids to do some of these.
So what you just described is, the biggest limitation of universal-based interventions. When you're trying to sort of get at everybody in a population regardless of their risk. And that's actually what this intervention is sort of testing. Would something like this work regardless? And that's sort of the prevention paradox, right? I mean, we know that those at highest risk wouldn't necessarily be touched by a universal intervention, but then you're shifting the distribution of the population enough that you have a public health effect, but you miss the highest risk people. So if those who are at sort of moderate risk, maybe you actually reduce their risk, and then the actual prevalence is reduced. But that's a major challenge with doing universal prevention. But that being said, I think doing this pilot work, we'll actually see a lot of what we're sort of missing, and how this would need to be tailored if we did an RCT, and if we could, because my whole point is try to keep it very brief. Because if we do it brief and we try, and we could try to disseminate it widely, then maybe we really could have an effect. But if we keep sort of changing it this and that, but we might need to, so that's the beauty of pilot work. So.
On that note, we should
Yes.
wrap up. Thank you to both speakers.